Welcome to today's webinar, PrEP 2.0, TDF and FTC and beyond, State of the Science and the Product and Delivery System Pipeline. I would like to introduce Raphael J. Landovitz, MD, Associate Professor of Medicine, and Associate Director at the UCLA Center for Clinical AIDS Research and Education at the University of California, Los Angeles. Welcome, Dr. Landovitz.
Thanks, Tammy, and thank you, everyone, for joining today's IAS-USA webinar. Just a couple of housekeeping things as we get started. On the slide that you can see on your screen right now, there are some important instructions about logging in and some important reminders listed in red about pre-registration and the need to ongoingly type your name into the chat box, which you don't need to do any longer, but you do need to have been pre-registered to be able to claim continuing education credits for this webinar. In addition, I just want to thank everyone for joining today, and a couple of reminders. If you have not previously logged into the IAS-USA website in the past, you'll need to use your new your email address and reset your password to be able to register for your credits. This activity will be eligible for 1.25 CME credits. And the credits will be available after 5 p.m. Pacific Standard Time today if people are wondering when the credits will be available. These are the instructions for how to update your IAS-USA account. If you haven't done so, this will be required to receive your continuing education credits. As I mentioned, these are the number of credits that the webinar is certified to be able to provide. And there are also nursing and pharmacy credits available if that is applicable to your degree and your program. Again, the evaluations will be available by 5 p.m. today, as will your CME credits. Any questions about that, please check the IAS-USA website for additional information, or if you're not receiving the IAS-USA emails. These are the generous supporters of today's activity, and we thank them very much. In terms of this webinar, there'll be a couple of poll questions, and we'll do a practice one right at the beginning. The poll questions will show up in a separate window, and then you choose your poll responses in that chat box, not in that poll box, not from the chat boxes on the side. And then Michelle and Tammy will close the poll after the number of responses starts to slow down. There won't be music or anything like that. That will delineate the time when people are able to respond to the polls. If people do have questions, please type them into the chat box, and depending on how they fit into the flow of the webinar, we'll either try and answer them as we go along, or we'll answer them at the end of the webinar, and I hope that's acceptable to everyone. Okay, so just as a practice, here is the first poll question. From which geographic region are you viewing this webinar? Again, please click the answer in the poll box itself. And again, this is a practice just so everyone can be familiar with the system. And we'll give it just a moment. And again, Michelle will close the poll when the number of responses is slowing down. Okay, so people can see hopefully in the poll box that Michelle has closed the voting, and looks like the majority of participants are from the United States, with a broad global geography of of participants, so thanks everyone for joining from all over the world, and looks like the majority are from Northeast of the United States and the West, with a smattering from Southeast, Midwest, and Southwest. So that's how the polls will work, and thanks for participating in that little exercise. Okay. So as a second practice poll question and a reminder, the question is, when will the evaluation for this webinar, which you must complete in order to claim CME or other credit, be available on the My Activities page of your IAS-USA account? And this is not a trick question. This was in the previous slide, so hopefully nearly everyone will get this correct. Okay, the voting is now closed, and 85% of people heard the previous information that this evaluation will be available by 5 p.m. today. So for those who didn't have that as their answer, or were being particularly cheeky by choosing option 3, please do know that it'll be available after 5 p.m. today. All right, okay. So again, a last poll question just as practice, and we can sort of see where people are. Please rate your level of experience in HIV prevention. And again, to remind people, the scale is 1 is novice, 2, 3, and 4 are intermediate with increasing expertise, and 5 is expert. And of course, there's always an option to vote, to opt out of the voting. Okay, voting is closed. Looks like people are largely in the middle or somewhat expert, with again a wide distribution. So again, thanks for taking that poll. Okay, enough polling. So again, we're going to be talking about the current state of the science for TDF FTC PrEP, and what is sort of in the short and long-term horizon in terms of biomedical prevention development. These are my potential conflicts of interest, and these are today's learning objectives. So by the completion of this webinar, hopefully everyone will be intimately familiar, if not already, with the current evidence for the efficacy of TDF FTC based pre-exposure prophylaxis, both daily and on demand, and able to describe the range of PrEP agents that are currently in development, as well as some of the challenges with diagnosing HIV infection in the context of using biomedical ARV-based prevention strategies. So we do have 2 pretest questions just to sort of gauge for CME purposes how people are assimilating the information we're going to be talking about. So the first one is, which of the following is true about pre-exposure prophylaxis? First is TDF-FTC has not been associated with any reports of Fanconi syndrome in HIV uninfected PrEP users. Number 2, TDF-FTC is clinically protective against bacterial STIs. Number 3, TDF-FTC PrEP has not been associated with an increased risk of non-traumatic bone fractures. And last, number 4, both TDF alone and TDF-FTC currently have U.S. FDA approvals for HIV prevention. So go ahead and put in your responses there. And we're not going to go over the answers to these pretest questions right now. Hopefully the answers will become apparent as we go through the webinar, and then we'll come back to these questions at the end. Okay, great. And we'll move on to the second pretest question. Which of the following novel modalities is most advanced in its investigational clinical development for use in HIV prevention. A dapivirine vaginal ring, broadly neutralizing monoclonal antibodies like VRC01, which is infused intravenously, long-acting injectable cabotegravir, which is an intramuscular injection, and subdermal implants. And this was not meant to be a trick question, but I'm loving the diversity of our answers here. Okay, great. Okay, thank you for that. So now let's move on to a sort of a state of the science. I think many of you are aware that we have a large compendium of interventions which have shown to be effective or have a lot of clinical expert data that support their use as part of prevention services. Some of them have really good clinical data, and some of them less good clinical data that have really compromised the robustness of their scale-up and uptake. Today we're going to talk about pre-exposure prophylaxis, or PrEP, one of the more new entrants to this puzzle, this toolbox of prevention modalities. Oftentimes people ask, how did the concept of PrEP get born? And of course, no one knows the exact sort of sequence of events that led to the seminal trials, but a sort of a preponderance of evidence was certainly suggestive of how we got here. And everyone, hopefully on this call, is aware that there's a long history of the use of antiretroviral-based therapy for post-exposure prophylaxis. That if someone has a needle stick or a splash with HIV-infected blood or bloody body fluids, the administration of combination antivirals after that exposure has the ability to reduce the chance of the exposed individual from acquiring HIV by approximately 80%. Those are the best data that are available from a case control cohort from the CDC. But animal models suggest that one of the most critical parameters in the efficacy of post-exposure prophylaxis is the time from the HIV exposure to the time of the first dose. And if that's actually true, and if the goal is to minimize the time from the HIV exposure to that first dose of antivirals, then you could imagine for someone who might be recurrently at risk for HIV that it would be a particularly attractive notion to actually have the antiviral therapy on board in the system prior to the time that the exposure actually takes place, effectively limiting the time from exposure to dose to be essentially zero. That was sort of some of the thoughts that led to the initial trials of HIV, and many of you are also familiar with the randomized efficacy studies that support the use of TDF, FTC in a variety of populations. And I do want to make the caveat that this slide only depicts the efficacy studies that were randomized for sexual transmission. There was, of course, a randomized trial of TDF alone in people who inject drugs in Bangkok that also showed statistically significant efficacy for that intervention compared to placebo. But just briefly going through these studies of sexual transmission, and I choose to sort of depict it in this way because I find the quantity of efficacy data a little bit overwhelming when I see it in tabular format. So I created this slide to help me sort of keep in my mind the point estimates of efficacy that each of these studies showed. Of course, back in 2010, the iPrEx study, which enrolled 2,499 gay men and trans women globally, although overwhelmingly in the Andean region in South America, was the first study to conclusively demonstrate protective efficacy of TDF FTC compared to a placebo with regard to HIV prevention. Individuals were HIV uninfected, at risk for acquiring HIV, and followed monthly with serial HIV testing. They were also educated about adherence to the daily oral tablet. Safety laboratory monitoring was performed, condoms were provided, and other safe sex and risk reduction counseling was provided. And at the end, the 42 to 44% reduction in HIV incidence, depending on whether you look at the primary endpoint or the ultimate final trial results, was reported. And I think a lot of people were disappointed in that result. And of course, the devil of being disappointed with an initial point estimate result is always in the details, and we'll come back to those details in a moment. But chronologically, the next trial to result was, the FemPrEP study, which was a very similar design of TDF, FTC versus a placebo in HIV uninfected women in sub-Saharan Africa. And I'm sure everyone on this call knows that study was stopped early for lack of efficacy. And so the initial question was, that's very puzzling. Can this intervention work for perhaps men and not women, perhaps for MSM and not for heterosexual women? What is the origin of this result? And again, we're going to come to some potential explanations in a moment. I'm not ignoring what those might be. But the next trial to sort of result was the CDC-sponsored TDF-2 trial, which looked at TDF-FTC in heterosexual men and women in Botswana, and again found high levels of protection for the males in that study, 80% protection compared to placebo, but the women in the study had a 49% reduction in HIV incidence compared to placebo, but that result did not achieve statistical significance. So again, people were confused, and understandably so. And of course, the landmark Partners PrEP study run by Jared Beaton and Connie Kellum from the University of Washington looked at serodiscordant couples in Kenya and Uganda where the HIV-infected partner in each heterosexual couple did not yet meet local guidelines for going on antiretroviral therapy, and the HIV uninfected partner in each couple were randomized to either TDF FTC, TDF alone, or a placebo, for the first time demonstrated the statistically significant robust protection for women, 66 or 63% reduction compared to placebo, depending on which arm, and again, high levels of protection for the heterosexual men in this cohort. And I think there was a tremendous amount of excitement when these results came out that look at the power of this intervention across populations. And of course, the confirmatory test, or the study that was designed to be confirmatory, the VOICE study, which was, of course, a complicated 5-arm study that had both 3 oral arms and 2 vaginal gel arms. I'm not going to talk about the vaginal gel arms here, but the same 3 arms that were in the Partners PrEP study, TDF, FTC, and a placebo taken orally to a large number of women in sub-Saharan Africa, failed to show the same level of protection that has been seen in Partners PrEP. And so again, lots of confusion. And again, I'm not ignoring what people believe to be the explanations for this, and we'll come to that in just a moment. Just rounding out the randomized studies, of course, was the UK PROUD study led by Sheena McCormick, where UK MFM were randomized not to active versus placebo, but immediate versus delayed initiation of TDF FTC, and demonstrated 86% reduction in incidence in those who received the immediate TDF FTC intervention compared to those who were delayed, and the study was stopped early. And the little guy in the final graphic on this slide is wearing a beret because this study was done in France and Canada, led by Jean-Michel Molina, the iPrEx study, which used an on-demand or 2-1-1 dosing of TDF FTC or a placebo, whereby individuals at risk, MSM at risk, were instructed to take either, they were instructed to take a double dose of TDF FTC 2 to 24 hours before planned sexual activity, a second single dose 24 hours after that, and a third, again, single dose 24 hours subsequent to that for a single exposure, and then stop. Showed 86% reduction in HIV acquisition in those who were on the active intervention, and we can talk more about that if there are questions at the end. And of course, both consumers and providers were really confused by this sort of wide discrepancy in these efficacy results across different populations, and I think everyone on this call is likely aware of at least one of the explanations for this, and when people look at biomarkers of actually taking the drug, it shows tight correlation with the observed effectiveness. So if you don't take the medication, it doesn't work for you. Of course, there's the added nuance of the fact that some of the components of the TDF FTC pill penetrate significantly differentially into rectal tissue compared to cervicovaginal tissue on the order of about 100-fold. So that probably leads to less forgiveness for vaginal protection compared to rectal protection, and so that really, I think that we can all agree that the current thinking is probably that it's a combination of drug penetration into target tissues and adherence that led to those wide discrepancies in findings, and that vaginal protection requires a higher degree of adherence to obtain high levels of protection, and the pharmacokinetic and estimates of that are 6 or 7 doses per week to achieve high levels of vaginal protection, and probably a lot more forgiveness for rectal protection. Certainly 4 doses per week should provide high levels of protection, as we're seeing in some open-label follow-up studies, and there are some pharmacokinetic modeling studies that suggest that even fewer doses may provide some protection. Hard to imagine that being a clinical recommendation, however, to allow adherence to fall below an average of 4 doses per week. So with that understanding in hand, one wonders, okay, that's really exciting, high levels of protective efficacy. What are the side effects? And really, they parse into 3 large buckets. First, about 20% of people have a gastrointestinal startup syndrome, which often is not dose-limiting, and often people can be supported through it with symptomatic management. It's fairly infrequent that people need to discontinue the treatment for that gastrointestinal syndrome, and usually does go away within a 2 to 4 week time point. I think the 2 areas that we all worry about a lot is renal toxicity and bone mineral density loss. And renal toxicity I think, is the one that has gotten the most lay press attention, we've sort of learned a lot about the nephrotoxicity. Of course, we have a fairly good perspective on the nephrotoxicity of TDF from its use in the treatment of HIV-infected individuals, but we've developed a fairly nuanced understanding of what contributes to an increased risk of declines in estimated GFR or creatinine clearance in the PrEP context, and some elegant work by Monica Gandhi and her colleagues at UCSF have suggested, not a big surprise here, that older participants are more likely to experience significant declines in estimated creatinine clearance or GFR, as are people who started with a creatinine clearance that was 90 or less. Of course, the package insert for TDF FTC for prevention recommends that it not be used for anyone with a creatinine clearance below 60. Which, of course, with a number of patients with comorbidities or older patients increasingly uptaking PrEP is becoming an increasingly complicated question in clinical management that we can come back to at the end of the webinar if we have some time. Additionally, the same group did some really nice and elegant work quantifying the average number of doses per week that people were taking based on a variety of biomarker samples, including hair samples, and correlated declines in creatinine clearance with adherence. So this is a little bit provocative, because although we encourage people who are trying to take TDF FTC as a daily regimen, that is clearly the dosing regimen associated with the greatest risk for a decline in creatinine clearance, and less dosing, not surprisingly, was associated with less toxicity. So providers are put in this very sort of interesting position of trying to balance optimal efficacy with minimizing toxicity, and it's one of the biggest clinical challenges of managing individuals on PrEP is when one finds someone with a decline in creatinine clearance, and you're needing to have a conversation about whether TDF FTC PrEP continues to be a good option for them, whether less frequent dosing might reduce that toxicity, or what else you can do to help keep them HIV uninfected, and it becomes a nuanced clinical discussion. I do want to mention that although we talk about cases of Fanconi syndrome in HIV-infected individuals or people living with HIV who are on TDF-based ART regimen, there has been at least one case of Fanconi syndrome reported in someone taking TDF FTC for PrEP. So you might have noticed that was one of the answers to one of our pretest questions. This was someone in an open-label demonstration project that was conducted in Southern California. It was a 49-year-old white man who had a history of kidney stones but no other renal disease. There was actually some mild renal impairment at baseline, a creatinine clearance of about 80, not normal, who initiated daily oral TDF FTC, again, as I mentioned, in this open label demonstration project, and 12 weeks after PrEP initiation had both a drop in estimated creatinine clearance and hypophosphatemia with renal phosphate wasting. The participant did come off TDF FTC, and the abnormalities did resolve. So it did not cause permanent damage, but was sort of nonetheless the first reported case of a Fanconi syndrome happening in TDF FTC use for PrEP. And I have heard anecdotally of a number of other cases as well. So I do think, although a rare phenomenon, it is something that we should keep in mind when using TDF FTC PrEP. The other thing that I think is very provocative was a secondary analysis of the iPrEx study, that 211 on-demand dosing study that I mentioned, that Jean-Michel Molina had presented at CROI in 2015 and was published in the New England Journal that same year. An analysis that was presented as an abstract at CROI this past year looked at estimated GFR changes in the 211 dosing between the active TDF FTC and the placebo arms. And they didn't find a difference between the active and the placebo-dosed participants in estimated GFR. And while it is always an incredibly perilous and dangerous thing to do to make cross-study comparisons, this finding is a notable difference to the randomized placebo-controlled trials of TDF-based PrEP administered on a daily basis, where significant differences between active and placebo were seen almost universally for estimated GFR and creatinine clearance changes. So does this imply that a 2-1-1 dosing schedule has less renal toxicity? I have a hard time invoking that conclusion because one of the potential explanations for the 2-1-1 dosing being effective is that the average number of doses in the main cohort was about 4 doses per week, which should confer high levels of protection. And so, if one looked at a subset of people instructed to take TDF-FTC with daily dosing who were only taking it 4 doses per week, would we still see the same sort of statistically significant creatinine and GFR findings in those daily dosed intervals? So I think it's provocative. It's certainly not conclusive, and I think it's an interesting conversation opener to whether or not less frequent or on-demand dosing used less frequently might have less renal toxicity. Bone toxicity is the other toxicity that we worry a lot about with TDF, FTC, and again, we have a lot of experience with this from the use of TDF-based ART regimens in people living with HIV, where approximately 3 to 4% of bone mineral density at hip or spine is lost in the first year, and then it sort of stabilizes. In the PrEP space, it seems to be about 1 to 1.5% in the first year, and then appears to stabilize. And these data are from the iPrEx and other of the initial randomized trials, bone density sub-studies, and I think what's really provocative about these data is that when people actually stopped TDF FTC, the bone mineral density did return to baseline. And again, additional secondary analyses suggest a dose-response relationship to this bone mineral density loss, and on the slide now you can see some elegant analyses done by Kathy Mulligan and Dave Glidden, where they looked at people randomized to placebo versus people who were randomized to the active drug in iPrEx but weren't taking it particularly regularly versus people who were taking it with reasonable fidelity. And you can see a fairly consistent dose response in terms of the bone mineral density loss across those different modes of taking TDF-FTC. I will parenthetically say that Peter Havens recently published in CID a provocative analysis of an adolescent trials network study that actually found that although largely bone mineral density loss was recouped in these youth who were taking TDF-FTC PrEP, after they ceased taking the study product. The 15 to 19-year-olds actually did not return fully to baseline, and I think that's an important finding that we need to investigate further, because of course young adults and adolescents, or I think the currently in vogue term is emerging adults, are still accruing bone mass, probably until age 25 or up to age 30 even. And if we attenuate, or one of the complications of TDF FTC PrEP ends up being attenuation of the accrual of total bone mass, will that have implications later in life regarding bone health and susceptibility to non-traumatic fractures? I mentioned non-traumatic fractures because the clinical finding, despite all of these other bone mineral density changes that have been observed, is no difference between active and placebo arms in non-traumatic fractures, making the clinical significance of these changes a little bit unclear. So I think while we all worry about these findings, their clinical implications really are yet to be determined. It is clear that that more regular dosing is associated with more bone mineral density loss, and one thing that is certain is we need longer-term follow-up of people who have been taking TDF FTC to see if there are clinical sequelae of these bone mineral density changes while taking it. Again, here are some of the additional data showing the recovery of the DEXA findings within 6 months after ceasing the study product. Many people have asked whether there are any interventions that can be undertaken to mitigate this bone mineral density loss. And again, it's a little bit hard to be dogmatic about that without clear clinical implications. But I think if there were something that were easy to do, we would all want to do it to avoid these potential changes in bone mineral density. And many people have made analogy to some interesting data published by Turner Overton and colleagues from the ACTG, who looked in the context of HIV treatment. So people who are living with HIV or AIDS, who were beginning an antiretroviral regimen that included TDF. Of note, it also included efavirenz, which has important implications additionally on vitamin D metabolism and bone health. Looked at a regimen of supplementing with vitamin D and calcium versus a placebo supplementation, and the effects on bone mineral density is assessed by both DEXA and markers of bone turnover. And they were able to demonstrate with calcium and vitamin D supplementation a 50% reduction in the amount of bone mineral density loss, and that was DEXA quantified. So you might wonder, well, what about calcium and vitamin D supplementation in the PrEP context? Does that have any utility? And to date, no one has done the DEXA-based study to definitively answer that question, but a group at University of Southern California, as part of a demonstration project, did supplement with vitamin D alone, and the regimen that was used was 4,000 units per day. And again, without DEXAs to help evaluate this, there were changes in markers of bone turnover that suggested some protective benefit. And again, this was not a randomized study. This was a case control study of an open-label demonstration project. So I think we need additional data, and there's a question that came in asking about if there's any data on bone mineral density loss on transgender female or trans feminine patients who are taking estrogen and TDF FTC, and whether that worsens bone mineral density loss. And I am not aware of any data that address that. I know there are a number of demonstration projects in trans individuals that are ongoing. And I think we're all eagerly anticipating the results of those studies to finally provide some robust data on drug-drug interactions, renal and bone toxicity in the context of gender-affirming hormone therapy use. So I don't think we know the answer to that question yet, but thanks for that question. There's another question that came in about advising continuous PrEP to someone with established osteoporosis. That's an incredibly difficult clinical question. It's all about balancing risks and benefits. There may be some options that might be a little bit safer that are awaiting regulatory review that we will talk about in a little bit. But with an individual participant, you need to talk about risks and benefits with them directly. It certainly would give you a lot of pause to have someone with established osteoporosis taking something that you knew was going to lower bone mineral density. So it's an individualized decision at that point. Again, there may be some other options not too far down the line. Often people ask, does TDF FTC PrEP fail? And I think the million-dollar question, of course, is what does failure mean? I mean, a lot of the seroconversions that we have seen reported are in the context of PrEP inconsistent use or non-use, and I think that one of the more assuring properties of TDF FTC PrEP has been this seeming very small window where if people are taking it with any frequency at all, and this is really for rectal exposures that I'm talking about, that infections are either completely abrogated or people really are not taking it sufficiently frequently to generate or select for resistant quasi-species should HIV infection actually occur. I think there are a number of cases that have been published in the literature in which there have been really robust biomarkers that support that people were taking TDF FTC regularly, as frequently as seven doses per week on average, and there have been seroconversions notwithstanding, and the ones that have been published are listed on this site. I would say that 5 of the 6 of them are clearly provocative cases that need drilling down into a little more. One, I think there have been some questions about whether or not it's possible that TDF FTC was actually initiated during the eclipse period, or whether seroconversion might have occurred during a period of particularly low adherence. But 5 of the cases, I think, really parse into 2 categories. One is a situation where someone was exposed to highly resistant virus, and transmitted resistance, of course, does occur. Happily circulating strains that are highly resistant and would be resistant to both components of TDF FTC are relatively infrequently circulating. Of course, it does still happen, and it is a really sobering reminder that no prevention strategy will ever be perfect, and is a bolstering argument in addition to the observation of dramatically increasing rates of bacterial STIs, which of course TDF FTC does not protect against, for ongoing adherence to condom use as best as people are able to do so. I do think we need to be careful about how we message condom use, because we do believe that TDF FTC PrEP is highly effective for HIV prevention. So the arguments for ongoing condom use have to be around these rare cases of failure, but more importantly around the issue of the ongoing epidemic of bacterial STIs that we are seeing. But again, coming back to these 5 cases where seroconversion or HIV acquisition, to be more specific, occurred in the context of regular, almost daily PrEP use. In addition to circulating or transmitted resistance, there is at least one case, and this is the case from Amsterdam, of what I sort of think of as something called a inoculum effect, where in addition to there being multiple ulcerative STIs, it appears that there was an extremely high inoculum of HIV with repeated exposures from multiple partners that may have overwhelmed the protective efficacy of TDF-FTC, even when taken exactly as prescribed. And I think, again, this is a sobering reminder that similar to levees that are built on the side of a river are never going to be able to withstand changes that will cause enormous flooding and can overwhelm any man-made dam or levee structure to contain a river. There is no HIV prevention strategy that we've identified to date that will be 100% protective. So again, these cases just serve as a sobering reminder. I do want to talk briefly about the challenges of making an HIV diagnosis in the context of TDF-FTC PrEP use. I think the PrEP, the post-exposure literature, suggested that detection of HIV antibodies might be delayed or attenuated by the use of HIV antivirals, and the PrEP literature continues to support that with increasingly robust data. Increasing data, and I'm just showing one analysis by Deborah Donnell from the Partners PrEP cohort that showed the time to full evolution to FIBIG stage 5 in active PrEP versus placebo-treated participants in that study was 25 days compared to 17 days. And there was a 7-fold odds of more than 100-day delay in the detection of HIV acquisition by antibody measurement. And that was accompanied by a decrease in viral load. And I think the clear conclusion across all of these studies is that antivirals as pre-exposure prophylaxis does attenuate viral replication. It does delay the evolution of antibodies, and it can cause discordant or discrepant or extremely difficult to interpret HIV testing results, including going so far as to completely suppress HIV RNA, rendering viral load testing of limited or more delayed utility in identifying someone who may have acquired HIV on PrEP. Happily, the majority of these cases appear to be rare and fairly straightforward to diagnose, because most of these HIV acquisitions occur essentially in the context of non-use of TDF-FTC. But if someone is using it infrequently or acquired HIV during a period of non or minimal adherence and then initiates TDF-FTC subsequent to acquisition, the testing may be complicated, and even viral load testing by conventional methods may become increasingly difficult. In such cases, there are a variety of strategies that have been employed. Some people have gone to whole blood DNA testing, such as is done on heel sticks to diagnose newborn infants. That there's limited data that is additionally helpful, but it may be in some circumstances. Some people people are trying to use laboratory-based assays that are not routinely clinically available, such as virus culture or viral outgrowth assays, measures of immunologic measures to see if T cells have been exposed to HIV in the past. Of course, none of this available in clinical settings, at least yet. And so people are left with this conundrum of trying to decide if the probability of true HIV acquisition is sufficient to commit someone to lifelong triple drug antiretroviral therapy, or withdrawal of PrEP entirely, observation for some somewhat arbitrary time point, usually recommended to be 3 to 4 weeks, and seeing if the antibody response or RNA signal were to present itself at that time. Of course, the risk of stopping pre-exposure prophylaxis in someone who is ongoingly at risk for HIV acquisition is always a tremendously fraught one, as any withdrawal of pre-exposure prophylaxis could provide an opportunity for de novo HIV acquisition. And that would, of course, be a huge disaster and would want to be avoided. And then, of course, some people just choose to continue the daily oral TDF FTC and retest. And in some cases, that may be a perfectly reasonable thing to do. I would encourage people to check with RNA in settings like that, because it's going to become increasingly difficult to know if anything has changed, if HIV has been acquired, and it may be worth testing on different antibody platforms, as there may be cross-reactivity, so-called false positives on one platform that may not be replicated on another platform. And by that I mean, for example, if you are using the Architect platform, perhaps use a different one, perhaps the Roche platform, or if you have access to another antigen antibody laboratory-based assay at your site or from a reference laboratory, confirming using that is also a reasonable thing to do while continuing TDF FTC PrEP if you really are not suspicious of HIV acquisition based on exposure history and adherence. So what is the future of pre-exposure prophylaxis? Well, there's a long list here, and I'm going to go fairly rapidly here, as I think there are some exciting options in the not too distant future. There was some tremendous excitement early on about Maraviroc, of course, a CCR5 receptor antagonist that has regulatory approvals for HIV treatment. It's not used a lot in first-line treatment because it requires that virus be R5 for it to be effective, also having a number of drug-drug interactions that make its dosing somewhat complicated depending on what the rest of the background regimen is, and a collaboration between the ACTG and the HPTN looked at in a safety study at a 4-arm clinical trial led by Trip Gulick, Ken Mayer, and Tim Wilkin that was trying to figure out if there could be a safety difference. This was not an efficacy study between TDF FTC, you can see it in arm 4 over there on the right, and then Maraviroc with each component of the TDF FTC tablet. You can see in arms 2 and 3 there in the center, and then a Maraviroc alone arm over on the left. And this was done in approximately 400 MSM and trans women and a separate cohort of 200 cis women. And again, I cannot emphasize this strongly enough. This study was not powered nor designed for efficacy, but the findings were nonetheless a little bit provocative. There were, in the MSM cohort, 5 seroconversions, 5 HIV acquisitions. There were no HIV acquisitions in the cis women's cohort, and all of them were in a Maraviroc-containing arm. 4 were in Maraviroc alone, and 1 was in Maraviroc with TDF. What is provocative about these data is similar to my emphasizing that in the original effectiveness and efficacy studies of TDF-FTC, if you don't take the drug, it doesn't work. If you look in the right-hand column of this table, you can see that at least at the time of HIV diagnosis, 4 of the 5 really had no evidence of taking their randomly assigned study product with any regularity. One of them, the second participant there, did have a substantial amount of Maraviroc detectable in plasma at the time of diagnosis, but it's unclear whether or not there were levels present at the time of HIV acquisition. So I think for this reason and the additional observation that in a rectal biopsy sub-study of the HPTN 069 5305 study, which took colonic biopsies and did ex vivo challenges with laboratory strains of virus. The observation was made by Ian McGowan and his colleagues that in fact the Maraviroc treated participants whose biopsies were looked at were more infectable in this ex vivo challenge model than were the other participants' biopsies in that study. So those observations together, plus sort of the anticipated need for a daily pill, tampered enthusiasm about moving this product forward. And at least as far as I'm aware of, there are no planned phase 3 studies for Maraviroc for pre-exposure prophylaxis. So how about TAF-FTC? There's a lot of interest, and certainly we have a lot of excitement about TAF-FTC. TAF, of course, is a relatively novel tenofovir prodrug, tenofovir alafenamide, that has about 90% lower plasma tenofovir levels than does TDF dosing, and instead has much higher intracellular tenofovir levels compared to TDF dosing, and that may account for some of the observations of reduced both bone and renal toxicity that are observed in people living with HIV who are treated with TAF-FTC containing antiretrovirals compared to TDF-FTC containing antivirals. So I think there was a lot of excitement about whether or not TAF-FTC could be used as a potential PrEP agent. And I think many on this webinar are aware or were actually involved in the conduct of this study. This is called Discover. It was a randomized study of TAF-FTC against TDF-FTC in HIV uninfected MSM or trans women globally. The primary endpoint was when half of the population had reached 96 weeks after enrollment, and it was designed as a non-inferiority study. These were designed to be at-risk individuals by a variety of criteria, and enrolled over 5,000 participants. I think everyone's probably seen these results, but if you haven't, they're extremely interesting. And what I find most exciting about these results is the overall low incidence rates of HIV infection in both arms. In the TAF-FTC arm, it was 0.16 per 100 person years. In the TDF-FTC arm, it's 0.34 per 100 person years. And I think regardless of what benchmark one uses, as a likely background population level incidence rate, that incidence rate observed in each of these treatment arms is very low and very exciting. The incidence rate ratio between the two arms was 0.47, and they did meet the primary non-inferiority margin to declare TAF FTC non-inferior to TDF FTC, and supportive data about adherence suggested that really the majority, the majority of the infections in both arms came in people who really were not taking their tablets reliably, and really only one infection in each arm occurred in individuals who had dried blood spot evidence of sustained levels of TDF FTC, of TFVDP, which is the active metabolite in these dried blood spots. So very exciting data, and these data are actually now before the U.S. FDA. I believe it was just announced this morning that the FDA is convened an advisory meeting on August 7th of this year as part of consideration for regulatory approvals, and I think it's going to be very interesting to see what the FDA does with this. Just before I move on to long-acting agents, I do want to say that I'm obviously aware that TDF FTC is about to be generic in the United States and is already generic in many parts of the world, and obviously price differences are going to become an important consideration in any decisions about the utility of this new agent. I'm not going to have time to show you these data, but additional analyses done in Discover did show markers of renal function and DEXA-based bone changes that favored the TAF FTC arm over the TDF FTC arm, at least in the short term. Moving on to long-acting agents, many people are concerned about long-acting agents. Many people are excited about long-acting agents. And I have this slide that I like to show where I say, is it good, is it bad, is it ugly, or is it just we need more information? And I think I come down on the side of we don't know the answer yet. I mean, what's good about long-acting drugs is they might not require daily adherence to any sort of product and take adherence out of the picture, and if they could provide sustained levels of protection absent daily dosing, I think that's powerful. Of course, what's potentially dangerous about them or concerning about them is, when you stop them, they persist in the body for a long period of time, and at least in the prevention context, what does that mean if you have a constantly waning level of an antiviral drug in the blood plasma and you're exposed to HIV? At some point, it's not going to be protective anymore. That's assuming there's protection in the first place, which hasn't yet been proven. And are you then at risk for seroconversion with potentially resistant virus to whatever the long-acting agent is? And you can see that depicted in the graphic on this slide. So I think the answer still remains to be elucidated, but it is a double-edged sword. What's good about it is also potentially its greatest Achilles heel. There was some very, very exciting interest in long-acting rilpivirine. It's a drug that has an excellent safety track record as part of combination antiretroviral therapy for people living with HIV, and it is also available not only as a daily oral tablet, but via an intramuscularly injected nanosuspension. It is, of course, a non-nucleoside reverse transcriptase inhibitor with a long half-life. And it was studied in a phase 2 safety study that was led by Linda Gale Becker and Neera Sista at the HPTN, where after an initial safety lead-in period of 4 weeks of oral dosing of the short-acting version of this drug to establish tolerability, and this was placebo-controlled because these were low-risk HIV uninfected women. They received 6 every 8-week injections of the long-acting version or a saline placebo, and then had a follow-up period. And the results were really exciting. The injections had to be administered as 2 2-milliliter injections, and they were safe and well tolerated and acceptable. And the pharmacokinetic targets based on non-human primate protection models were met, but it does require a cold chain, at least in its current formulation, and is light sensitive, which was concerning in terms of global scale up and interest. And then there was this observation in one of the phase 1 studies where someone received a single dose of about a quarter of the dose that actually went into phase 2 as a single injection, and then was exposed to HIV about 40 days after the injection was given, and ended up acquiring HIV with the K101E mutation, which has the potential to compromise the antiviral efficacy of at least a efavirenz-based treatment, which until recently was first-line treatment globally. So I think the potential, the realized concern about generating viral resistance to one of these long-acting agents during the pharmacokinetic tail, and the need for cold chain and light sensitivity. And someone asked, what is cold chain? Means it needs to be held at a constant refrigerated temperature in order to be stable, which may not be tenable in some geographies and settings, particularly in rural settings or where there has to be drug transported over prolonged distances, or refrigeration is not constant. Although every time I've heard that argument brought up, people do point out that Coca-Cola is kept cold and shipped all over the world. So if we can figure that out, we should be able to figure this out. And I hope that that's true. I hope that it is something that we could work through with political will and enough resources. I'm going to briefly talk about long-acting cabotegravir, and full disclosure, I think many on this call know that this is something that I'm involved in the development of on the NIH sponsored study side. So I can speak to it a little bit from some personal experience here. Cabotegravir is a novel integrase inhibitor that, like rilpivirine, is available both as a daily oral tablet and as a long-acting injectable suspension. It is a new integrase inhibitor with a prolonged half-life when administered intramuscularly. On the prevention side, there was a phase 2 study that was done in U.S.-based men, and again, it had this very sort of familiar study design. It had a 4-week oral lead-in. It then had 3 injections done at quarterly intervals of long-acting injectable cabotegravir. Again, this was 2 2-milliliter injections to get a dose of 800 milligrams, and then a prolonged oral follow-up period. Again, this was placebo-controlled because these were HIV uninfected, low-risk individuals. And these were sort of the primary pharmacokinetic findings of ECLAIR. And I just show this briefly to show that this is really why you do phase 2 studies. In purple was the phase 1 data for cabotegravir every 12 weeks that suggested that, at least based on the non-human primate models of rectal protection, quarterly dosing should be perfectly fine. But the green lines show what they actually found in Eclair, and what you'll notice here is the green dots drop lower than the purple dots did, and that's because the drug washed out of the participants in Eclair, and these were again all males, at a faster rate than was anticipated from the phase 1 studies. And it was on that basis that a different dose was modeled and tested in additional phase 2 studies, and that's the dose that ended up moving into phase 3. So the second phase 2 study that actually evaluated that new dose had 2 cohorts. It was called HPTN 077. The first cohort was designed very similarly to the Eclair study, but involved both men and women, and it was global. And then on the bottom of the slide, you'll see there's a second cohort, and this is one that looked at this 600 milligram dose of cabotegravir or a matching saline placebo. That was a single 3 milliliter injection injected in the gluteal muscle, and it's injected every 8 weeks after an initial 4-week loading dose. And these participants were followed for 5 injections, and then up to 18 months after their final injection to better characterize the pharmacokinetic tail. And these are the results of the pharmacokinetic tail study findings from 077, and I would encourage you to look over at the week 76 data. So this is literally 18 months after the last injection. And for the males in the study, 13% of them still had detectable cabotegravir concentrations 18 months after their final injection, to give you a little bit of a sense of how long this pharmacokinetic tail is. And the females in the study, actually 42% of them still had detectable cabotegravir levels, again, 18 months after their final injection. And the team did a little bit of modeling, and the average, median actually, number of weeks it would take after a final injection for the cabotegravir to get to undetectable levels was 43 weeks essentially for the males and 66 weeks for the females. So again, just describing this long pharmacokinetic tail in a little bit more detail. Cabotegravir is currently in phase 3 studies for pre-exposure prophylaxis, supported by those phase 2 studies. There are sort of twin or sister studies that are evaluating this, one for MSM and trans women and one for cisgender women in sub-Saharan Africa. The studies are ongoing, and we're hoping for results in 2020 or 2021. I do want to have a brief moment to talk about antibodies to be used in vaccination efforts and HIV prevention. We have a long history in infectious diseases of using monoclonal antibodies to prevent or treat different infections, so not something that's entirely new to the field. And of course, there's a burgeoning interest in the so-called broadly neutralizing antibodies, which are derived from patients who generate these antibodies against HIV on their own, given chronic infection. Some of them have the ability to control or neutralize the HIV virus, and so they've been studied extensively in the laboratory, and in the laboratory these antibodies have been optimized and genetically modified to have improved pharmacokinetics and improved specificity, and the science, and it sounds almost too fantastic to believe, but it's really incredible the progress that has been made in a short term. You can see here the incredibly large number of antibodies that have gone into various stages of of evaluation, and their various targets are denoted by the various colors of the dots, and their potency is along the x-axis, and their breadth in terms of the proportion of HIV isolates that they neutralize along the y-axis. So tremendous excitement, and basically by the time this webinar has ended, there probably will be 3 or 4 new broadly neutralizing antibodies that have been developed and will be moving into development. The field is moving incredibly fast, and it's exciting. And of course, a proof of principle study that this can actually work as a preventive agent and get a better understanding of why it might not work is fully enrolled and ongoing, co-sponsored by the HPTN, the HVTN, called the AMP studies, and we're eagerly anticipating those results. It's going to be very interesting to see what they find and what the implications are for the future development of these antibodies for prevention. I want to also briefly mention implantable devices, kind of like the hormonal contraceptive implants that are available as part of family planning. Requires a small surgical procedure to insert, and most likely a small surgical procedure to remove. Can last for months to years, and it would be really exciting if we had drugs that could be HIV preventive as well as potentially including family planning activity in a single implant or in multiple implants as an additional option for people. There are a number of exciting drugs that have properties that make them attractive for studying in this context, and we look forward to early phase results to see what's feasible in terms of drugs. Of course, you have to be concerned about whether there could be a dumping effect, so a large amount of drug dumped out inadvertently from an implant, or local inflammatory effects, and those sort of operational and considerations are going to make this a little bit more of a slower development process to regulatory approvals, because you're really developing both a device and a substance, a drug, at the same time. I do want to mention, I would be really remiss if I didn't mention the monthly dapivirine ring, which showed approximately 30% efficacy in 2 phase 3 trials and is currently before the European Medicines Agency, the EMA, for HIV prevention in women. So this is actually the next PrEP product that is the most advanced in development. It has actually completed its phase 3 studies. Its primary results from open label extensions that suggest a 50% reduction if used closer to as prescribed, and it'll be very exciting to see what the EMA, the European Medicines Agency, does in terms of increasing the choices that we have for HIV prevention, particularly for women in sub-Saharan Africa. And the last technology that I'm going to just mention briefly is something that I find just fascinating. Microneedles. So there are these patches, roughly the size of a Band-Aid, that have small prongs on them that can deliver a substance or even a vaccine product or an antiviral into the stratum, into the dermis. So you get through the stratum corneum, they get delivered into the dermis above the levels of the nerves and the blood vessels, so they're not painful, and you don't get systemic administration of them, and they're absorbed by the antigen-presenting cells in the dermis. This is an electron micrograph of a mouse ear that was punctured essentially by one of these microneedle patches. And in some early vaccine studies, these were shown to be highly antigenic, almost as strong an antigen response as prime boost strategies for some vaccines. This is a graphic of how this might work. A patch with some needles that would penetrate the stratum corneum and then deliver a dissolving substance into the dermis that could then deliver a product on a sustained way, and then the patch would be removed. This is a fingertip showing the actual size of these microneedle patches, and again, early studies in vaccines, not HIV vaccines, but some SIV analogies show them to be highly antigenic, and there's a group at Queen's University in Belfast, led by Ryan Donnelly, with collaborations from PATH and the POP Council and ViiV that are looking at cabotegravir in a microneedle patch. So I think this is potentially tremendously exciting. So again, the last thing I want to say is the case that we really saw. A 60-year-old man returned for PrEP follow-up, had been on TDF FTC for 2 years, excellent adherence, was having 7 male partners in the last month, and had STI testing and a 4th gen that was negative 3 months ago, and now comes in with reactive 4th generation test results. A confirmatory IFA is negative. All his RNA tests are negative, so not detected. He had a normal CD4 CD8 ratio. His whole blood nucleic acid tests were negative, and the question is, what do you do? So, little end of the webinar, are you still awake question. So are these false positive results? He's definitely HIV infected. It's unclear if he's infected. Hold PrEP and retest in 4 weeks. These are likely false positives, but retest using a different platform. Or I have a headache, stop asking me questions. Okay, so clearly many of you were listening, and I think it's true. It's likely a false positive. I would try retesting, but then you get into this really complicated system, the situation of whether you should hold PrEP if you're unable to get clarity with repeat testing and see if anything manifests in 3 to 4 weeks. I think very few people in the United States would ask this person to consider taking a 3-drug regimen for perpetuity. Based on these results, they would want something more concrete as evidence of actual HIV infection before doing so. But there are some groups and some parts of the world where the opportunity to not miss hyperacute treatment of HIV would recommend 3-drug fully suppressive therapy for such an individual, and only drug interruption in a carefully controlled clinical trial setting. So I think we have a lot to learn about HIV testing in the era of PrEP, and it's only going to get more complicated with some of these long-acting preparations and broadly neutralizing antibodies. And I think we're going to need better diagnostics and more available clinically, commercially, and at point of care if we're going to be rolling out these products globally. And I think this is an underappreciated challenge of some of these long-acting preparations. So I don't propose to have all the answers to these sorts of questions by any means. I just want to bring it up so everyone has it on their radar screen, because I think it is underappreciated that this can be really, really challenging. Okay.